Hey guys, today I'm going over methotrexate. It's a high-risk drug, meaning that at least one of the questions in the exam will be about it. Also, it has a pretty cool name. To make this poster, I used my notes from the primary HD seminar I attended, the EMC, BNF, and Top 100 Drugs book. So, methotrexate has the following indications. It's a DMARD for rheumatoid arthritis. It's used in chemotherapy for cancers like leukemia, lymphoma, and solid tumours. It's for severe psoriasis that's resistant to other therapies, and for maintaining remission and treatment of severe Crohn's disease, which is an unlicensed indication. In terms of how it works, it's classified as an anti-metabolite cytotoxic agent. It's a folate acid antagonist which prevents cellular replication, so that's how it works in cancer. And it also has anti-inflammatory and immunosuppressive effects by inhibiting TNF-alpha and interleukin 8. So now that we know how it works, we can gauge an understanding of the side effects and monitoring. Mucosal damage, which is things like a sore mouth, GI upset, and stomatitis. Stomatitis is a red flag side effect. Bone marrow suppression and blood disorders, so neutropenia, increased risk of infection. This can present as a sore throat, bruising, mouth ulcers, fever and rash, and these are red flag symptoms to alert the patient about. Rarely it can cause cutaneous reactions and pulmonary toxicity or pneumonitis, so this presents as shortness of breath and cough, and long-term use can cause pulmonary fibrosis. It can also rarely cause liver toxicity or hepatitis. This presents as jaundice, nausea and vomiting, abdominal discomfort, and dark urine. We would monitor blood, so do a full blood count because of the blood disorder side effect, and we would do LFTs to check for liver toxicity. And finally, I've written at the bottom of the page that you can't see that methotrexate is excreted renally, so we would check urinase as well. So the typical dose for methotrexate is between 7.5 to 20 milligrams weekly. There's an MHRA alert because taking it more frequently can cause an overdose, leading to toxicity. It's really important to inform patients that it's normally a weekly dose. It should be dispensed as 2.5 mg tablets, not 10 mg ones, for this reason. Folic acid 5 mg is usually given alongside methotrexate to reduce side effects, either as a daily dose or a weekly one, which is given on a different day to the methotrexate. So one way to inform patients to help them remember is methotrexate Mondays and folic acid Fridays. In terms of interactions, there is reduced excretion with NSAIDs and penicillins, so an increased risk of toxicity. Methotrexate also interacts with other folate antagonists, so trimethoprim and phenytoin, for example. There's an increased risk of neutropenia if used with clozapine, and due to immunosuppression, live vaccines should also be avoided. For this reason, it's really important to counsel patients to use effective contraception during treatment and for 6 months after. Ignore the fact that it says 3 months. I checked the EMC and it says 6. Because of the cytotoxic effects of methotrexate, there's some important handling points. With all cytotoxic drugs, protective gloves and goggles should be worn to avoid the drug accidentally coming into contact with the skin or eyes, and pregnant staff should avoid handling it. And finally, one more point is that it is contraindicated in severe renal impairment and in hepatically impaired patients. Okay, so that's all of my methotrexate key points. This poster was not prepared as well as the other one, so as you can tell, it's a bit imbalanced. But the most important thing is that all the key points are on there, so hopefully you've learned from it. And thanks for watching.